All right, so this will kick off our afternoon session on the role of carbon fiber implants in the management of spinal tumors. So what we'll do is we'll just start off with a brief case presentation. I'm going to go over some of my personal indications for carbon fiber instrumentation. I think by far the most common indication that we've all come across, especially after hearing some of these great talks today, is really for metastatic vertebral column disease. Over the last few years, there's been a marriage between separation surgery and carbon fiber instrumentation. So when we have a case like this is a gentleman with carcinoid tumor. Rather than performing a complete corpectomy, taking out the vertebral body, really the concept of separation surgery entails only taking out that ventral epidural disease and then subsequently sending the patient for postoperative stereotactic radiosurgery. This is a very brief operative video from this particular case that shows us placing our carbon fiber screws above and below the index levels. What we're doing now is taking down the pedicle. This is the medial pedicle wall. We've ligated this thoracic nerve root, and we're using what's called a Mott dissector to separate the tumor away from the ventral epidural compartment here. And again, Dr. Laufer had alluded to this morning. A key component of separation surgery is making sure that you cut the posterior longitudinal ligament. And then at the end of these surgeries, we do like to bring the ultrasound in to ensure that we've got a nice circumferential decompression. The second indication, or this is the postoperative film that shows carbon fiber screws. The second indication here that we'll briefly discuss is that of primary bone tumors. This is a 23-year-old gentleman who had presented to us with bowel and bladder incontinence, also had neurogenic claudication for several months, had difficulty using his legs. We can see that there's a fairly large lytic mass that's centered at about L2, L3. These patients typically we would send for preoperative embolization, and this is a very short video clip as to how we go about removing these. Again, we're placing our carbon fiber instrumentation above and below. We're opening up the muscular envelope. We then subsequently cauterize the capsule of the tumor. After performing a laminectomy, we're able to peel the tumor off the thecal sac and then resect it, and we can appreciate our short segment carbon fiber construct with one up, one down. Here's the specimen relative to the axial cut, and just for comparison, this is what a postoperative CT scan would look like with our standard titanium screws and cobalt chrome rods, and this is the one-year follow-up postoperative MRI scans we can see. The last indication, or I should say the third indication for carbon fiber instrumentation is a little bit debatable. I think placing instrumentation for intradural cases are really few and far between. This would be one of those rare indications. If you have an intradural ventral tumor that's calcified at the cervical thoracic or thoracolumbar junction, such as this case, I think one can make the argument to have a better line of sight to get access to that ventral intradural compartment so we can have a nice surgical corridor to resect these tumors. And again, if you're at the CT junction or the TL junction and you have to take the pedicle and facets down, one may consider placing instrumentation. And again, in my opinion, this is a fairly reasonable indication for carbon fiber instrumentation. The last indication would be for complex spinal schwannoma. Some of these tumors, they do tend to migrate out of the neural foramen. And for those of us that resect these to perform a complete resection, sometimes we do have to take a pedicle and a facet down. So again, this would be another reasonable indication for carbon fiber instrumentation here. What we're doing is after we place our screws, we're opening up the dura, we're resecting the intradural components of the tumor. We're now taking the extradural part out, and we can see on the postoperative MRI scan that we have a very reasonable construct. This is a patient presumably with a normal life expectancy, and now we're able to follow her MRI scans without any radiographic artifacts. And this is what her postoperative x-rays look like. So I'd like to introduce two of our radiation oncology colleagues that are here with us today. We have Dr. Joshua Palmer, who's an associate professor of radiation oncology at The Ohio State University and James Cancer Center, as well as Dr. John Kresl, who's the medical director of the Phoenix Cyberknife and Radiation Oncology Center. So welcome to our featured panelists. So what we'll be doing over the next 20 or 30 minutes, we'll be having kind of a collaborative discussion on some of the indications and nuanced details about carbon fiber fixation. So the first question I'd like to ask, I'll ask Dr. Palmer first. You saw the surgeon's indications for carbon fiber. What are the indications from a radiation oncology perspective that maybe I didn't touch upon?
Well, I think they overlap quite a bit. For the radiation oncology indications, we typically would want any patients who are getting instrumented, who have an oncologic reason to have postoperative radiation treatment. So that would include like a fractionated approach, either with proton therapy or with a radiosurgery-like approach. Typically, from our perspective, we rely a lot on our multidisciplinary discussion to find a prognosis for the patient, because oftentimes when we're thinking about the carbon fiber constructs, we're, in part trying to make certain that we can get good postoperative imaging to allow us to define the target and then provide the local control. But I think in tandem to that, if the patient's prognosis is quite poor, then our treatment choices change quite a bit from a radiosurgery approach to a more conventional approach. And then from our perspective, the use of carbon fiber for longer term follow-up or for treatment and tumor delineation, if we're doing something more conventional with a postoperative spine metastasis, then that becomes less useful. And so a lot of times, like the indications you showed are sort of what we would typically use for the carbon fiber constructs in the thoracolumbar region. But adding to that would be sort of our overall prognosis for the patient and how useful is having that improved imaging characteristic for follow-up and sort of helping us determine treatment delivery, whether it's a more proton or photon-based radiosurgery or a conventional treatment.
Dr. Kresl, what are some of your experiences in regards to the consequences of the choice of material that we use in spine surgery? Let's say, for example, if we were to use titanium and cobalt chrome in some of these metastatic spine tumor cases as opposed to carbon fiber, what are your experiences in postoperative SBRT planning?
So before I answer that one, I just want to piggyback on what Dr. Palmer mentioned. I think the one category that was maybe not mentioned that we see quite a bit of is retreatment. So there's quite a few oncology patients now, as the systemic therapies are getting better and patients living longer, that those patients that have had prior surgery and or radiation, conventional or otherwise, are many times having recurrences. So in retreatment and separation surgeries or debulking prior to another course, in this case usually SBRT for retreatment, the carbon fiber implants become a very important consideration. With regards to your question, many times we're limited. If we get a patient in the postoperative setting that has non-carbon fiber constructs, the imaging is sometimes very difficult. For radiosurgery, one of the major components of it is to be able to delineate and contour not only our target, but also surrounding critical structures. So in many cases, that's the spine and the spinal cord and the nerve roots. So if our imaging is already full of artifact, many times we're limited in being able to identify the targets. And when we can't delineate the targets, we then have to usually default to fractionated therapies that pose a little less of a risk to the critical structures with regards to long-term radiation effects. In a similar fashion, not just with regards to imaging and delineation, but the non-carbon fiber implants many times will also pose a challenge to us with regards to dose delivery and taking into account the attenuation of the radiation therapy as it interacts with different metals and different compounds, to be sure we know exactly how much dose we're delivering to a certain location in and around metal constructs is a big challenge in and of itself also. So I think those are the two factors, at least, that are foremost in a radiation oncologist's mind when they're looking in the postoperative setting with or without the carbon fiber constructs.
Dr. Palmer, how critical do you feel that it is to have a complete carbon fiber system, carbon fiber screw, tulip head, and rod, as opposed to maybe one of these hybrid systems where you may have a titanium tulip head or a titanium rod with a carbon fiber screw? Is that impactful in any way to the radiation oncologist?
I would say yes, because there's a lot of sort of small things that are important with the components that are used for the postoperative stabilization and how they have implications for our treatment planning and delineation. And a lot of it has to do with patient-specific factors as well, because depending on the patient's overall body habitus or the tumor's location, because occasionally tumors can also go extraosseous, either paraspinal, or go into the musculature where the tulip heads are. That can sometimes cause some challenges depending on which system and how much titanium is used. For instance, if there's titanium tulip heads, depending on if you can put carbon fiber rods, that can decrease some of the attenuation and the imaging can still be quite good. But if you end up having just carbon fiber screws and titanium rods with titanium tulips, what it ends up doing is, depending on how much the sort of patient's thickness is, when we do the imaging, you can actually get enough sort of titanium attenuation that you can actually cause some difficulty seeing the tumor even with a partially carbon fiber construct. And we've run into that in some of our patients, depending on how much titanium is used, especially if it's a mixed titanium carbon screw construct, where if the contribution of titanium attenuation around the tumor can actually cause some difficulty. And I think another key component is the use of cement, because oftentimes if we're using a smaller construct, our surgeons will use a sort of cement augmentation to then strengthen if it's only one above and below. The challenges that come with that is that the one above and below, if there's enough titanium posteriorly, that can actually cause some difficulty on MRI imaging, to the point where you may still require a myelogram to adequately see the true extent of the spinal cord. Or if there's extraosseous disease, you may not fully be able to identify it on the postoperative imaging. So I think it's critical, the more carbon fiber that can be placed, and when we utilize cement, making certain that we don't inject enough that we can't see the tantalum tip anymore, because like we'll get into, I think we particularly use that to track the patients for treatment. And if you use enough cement, even the density from the tantalum screws or the actual construct of the carbon fiber tip that's wrapped in titanium for some will be quite difficult to discern on imaging. And so we have to sort of, it's crucial that the surgeons and the radiation oncologists kind of think about how do we go about the placement of the various titanium components, so that we can actually plan out, does this patient need additional imaging to be able to provide us with the appropriate sort of delineation for the tumor or not. But I guess the long and short of it is, the more carbon fiber that can be placed, the better it will be for both delineation and follow-up.
So, Dr. Kresl, just to piggyback Dr. Palmer's statements there, are you having a conversation with your spine surgeons before an operation to plan this out? Is that even discussed? So that's the first question. The second question is are we still seeing CT myelograms? Is there still an indication, even with carbon fiber instrumentation, or radiation oncology colleagues still completely, absolutely just relying on MRI scans at this stage?
So first off, yes, I work as hard as I can to have those conversations ahead of time. You know, the multidisciplinary tumor boards are a good forum, and a lot of patients are seen there in a prospective fashion where we can have that input and have that discussion. The more difficult cases are the ones that are perhaps seen in the ER, and surgeons are making the appropriate decisions, but without maybe thinking beyond the emergency setting for debulking or decompression. And then we're left with patients in the postoperative setting that may have benefited from carbon fiber implants that we're not able to have them. But as much as possible, if we see them, meaning the rad oncs are seeing them before surgery, that certainly is a discussion that we have. The tumor boards is now it's a common discussion. And more surgeons and more radiation oncologists in Phoenix are becoming aware of that as they participate in those tumor boards. So we're trying, again, at this point, it's early on, and it's education, and also as we're discussing now, the big issue is identifying what are the appropriate patients, for this to be considered in, as we try to all help define that going forward. And then finally, the last question had to do with, again, one more time, with what the
indications for continuing to still get CT myelograms as opposed to postoperative MRI scans.
Just had to get a couple this last week. Again, there are patients where the myelogram is important in addition to whatever type of imaging is available. We try to complete as big a picture with multiple sources of imaging to help us delineate when needed. But in cases, both of these cases were long-standing patients with metastatic breast cancer, been alive a long time, had very low disease burden, under active treatment, but had progression within a previous spine field that had standard fractionated conventional radiation, had compression fractures, and went through debulking without being able to completely remove all of the disease en bloc. So consideration for SBRT to the residual bony structures and areas of microscopic residual was recommended. And to do that, I needed myelograms to best determine where cord was.
I think it's worth bringing up how we go about getting carbon fiber implants approved in hospital systems. I've worked in two different academic centers, one in New York, now University of North Carolina, and it's a several-month process. So I'd like to hear from the private side and the academic side, how do we navigate the cost of carbon fiber PEEK within your spinal oncology practice, and does it impact the economics of practice in your hospital systems? Maybe Dr. Palmer, do you want to take that on first?
Of course, sure. And so I think in part it's sort of a collaborative process between the neurosurgical department and the radiology department. And we were very lucky to have Dr. Mendel with us when we started this process to kind of go through the nitty-gritty with hospital administration. I think the challenging thing is because of the cost, a lot of what we had discussed with the administrative teams is the benefits to the patient. And so there is a cost savings over time with the less utilization of a myelogram and the resources that are required for that, as well as sort of the improvements in detection of recurrences and the ability to kind of, hopefully not have to revise or go back and do additional treatments for patients who were either inadequately treated due to not being able to identify the tumor well enough, or the construct failing from a tumor recurrence. And so I think a lot of it is sort of a discussion that the overall downstream effects that are improved with this type of construct and the things that we can do to help patient care. I think that was a critical role, especially driven mostly by, I think, in my opinion, the neurosurgical department, but also with a discussion that it helps multiple downstream team members, because obviously the radiation oncologist would really benefit from an improved postoperative imaging to be able to delineate the tumor. So we have made that very clear to our team members.
Dr. Kresl, I'd like to hear your experience as well in the private setting.
So in the private setting, it's very similar. First and foremost, always has to be patient care and clinical outcomes and clinical rationale. Then you build off of that with regards to identifying physician champions in the different specialties that it overlaps with: neurosurgery, radiology and imaging, radiation oncology, even oncologists, and going through the process of how this can provide the best level of care for properly selected patients. And then the last part is then trying to also put together a pro forma or a a rationale from the financial aspect to talk to administration with regards to, yes, the individual costs of maybe the constructs are higher when you compare just those constructs. But from the time the patient enters your system until they've been in your system and undergone multiple forms of treatment and imaging and follow-up over a 2-3 year time course, what is the actual difference in cost or cost savings? And I think now there's even some preliminary evidence with regards to reducing the time in the hospital and the post-operative setting, as the imaging can be done more quickly with regards to ensuring proper post-operative care and discharge. And maybe even some additional information now is coming out that it doesn't add to post-operative time or risk of wound infection. So again, those are all the things that you have to use in concert to build the whole comprehensive story for administration as to why these should be included. And then finally, the last discussion I usually have with administrators and hospital systems is that, without it, there are other systems in the area that it is available, and those cases will be lost to your system and go elsewhere without these capabilities being available in your system.
So does this impact your referral pattern to specific centers that have access to carbon fiber peak instrumentation at all?
It does. When the patients are seen by myself or colleagues that are considering patients for carbon fiber and SBRT in the post-operative setting, typically then we have the opportunity to reach out to the neurosurgical community that we have available to us as to, who has the experience, who's interested in that type of procedure and construct utilization, as well as which systems they have privileges into, to conduct those surgeries. So that happens kind of in a broader, macroscopic level throughout the community and state. And then in a little bit smaller environment are these CNS tumor boards that I spoke about earlier. In those tumor boards, there are, some physicians that have that experience and some who do not. And in the course of those discussions, deference is kind of made to those physicians who have the experience who are interested and able to, provide the carbon constructs that will receive those patients and those referrals from within the tumor board. So in that setting, yes, it does make a difference as to how my referral patterns have changed.
Yeah, I'd like to just add, Michael, that and Josh knows this, just like I got the carbon fiber into the James, which was a process. It almost took a year to be able to get the carbon fiber system up there. Luckily here at Smiler, we were able to get it here too. And but it is a process, right? You got to go through explaining the pros and cons of the cost is a huge issue when it comes to the pellicle carbon fiber screw versus the titanium. It's a significant cost issue, especially now with a lot of hospitals, trying to figure out cost-saving measures, and a carbon fiber sometimes can look as a luxury option when you do have the titanium screws. Luckily, I have great colleagues, and actually I saw Max here on a call. Max is in the leadership administration here at Smilo, and maybe Max, you can talk to us about when I came in and say, hey, we need carbon fiber. What do you think? What were you thinking? And luckily, Max is a neurosurgeon who does some spine tumors too. So how do you see it from your point of view? Because here we are talking about all the pros, but you and I talked about those other issues that are definitely big issues when it comes to getting the system into any hospital system.
Yeah, and Udi, I was reflecting as I was listening to the discussion. I was reflecting on exactly that experience that you and I had, and I was familiar with the technology and certainly saw at that time and still do see the benefits in using those kinds of using the carbon fiber screws in spine tumor surgery, in particular in the postoperative care. I think the cost analysis is really challenging here, because while some of the points that that were made in terms of, you know, less cost of myelograms, less cost in terms of future myelograms, less cost in terms of potential revision surgeries, those are valid. But from the hospital's point of view, who is the purchaser, and when you look at the P&L, the profit loss statement for these particular procedures, those additional procedures don't actually translate to cost savings. And in many cases, actually not having some of those additional procedures is a loss because of the fee-for-service environment that most hospitals are still in. And I think and it's not a reason not to bring it in. I want to be clear about that, but I also want us to be honest about the business models that are squeezing many of our hospitals today. And it's getting more and more difficult. You know, still over 50% of hospitals in the country are losing money following the pandemic. And it's getting more and more difficult to watch profitable procedures like spine cases become contribution margin negative, and figure out how you're going to continue with that kind of within those kinds of investments that we need to in these areas. And it's a reality of the environment that we're operating in. So I think they're all good points. It's an important technology that we have access to, but it is not straightforward as we think about how to bring in new expensive technologies like this.
And I think the solution to it is there used to be just two companies, and as just was mentioned an hour ago, there's a third company now that manufacture this kind of carbon fiber. The more the competition system is going to get in there, the prices are going to go down. Hopefully to the point where a titanium screw costs just as much as a carbon fiber screw. So it's encouraging to see that there is some competition there and there's no monopoly in this type of setup. Josh, I wanted to ask you something. So from what you said, just having the head of the screw as a titanium is still an issue. I mean, from your point of view, you would prefer a whole carbon system with no titanium whatsoever. Just a little bit of a titanium in the screw head makes a difference when it comes to your planning.
Well, I think the sort of tantalum tip of some of the systems is actually a useful piece. It's not large enough to cause a significant contribution to like an imaging artifact. It is, however, when there's a large amount of cement. If there's a large amount of extravasated cement around the tantalum, that can sometimes, in some patients, especially if a rod is also titanium, cause imaging differences so that it's very difficult with MRI alone. So some of those patients, just like for rough numbers, we used to do about 100 myelograms a year. We now do, for our postoperative radiosurgeries, now we do about like 5 a year. So it's very few. We've opened up a lot of those IR procedures to others because we used to hold them one every week. We used to hold those for potential post-op cases. We now no longer do that since we very rarely, only for cases that are like we're describing here, very difficult cases, either based on patient anatomy or some of the other choices that the surgeons have. But the tantalum screw, I would argue, is actually an inadvertent important kind of engineering process because we can use that for fiducial tracking. So like if there's a carbon fiber construct that just wraps the screw in titanium, that's not as useful for at least for the radiation oncology side, because then we end up having to track the tulips, which is our other alternative if we're going to use IMR tracking, but that becomes essentially the same as titanium. And so we do oftentimes use just tracking the whole construct itself, like if it's made of titanium or if there's no fiducial marker that we can track. But if there is a tip that's used, that's actually helpful to us. It doesn't end up contributing to the imaging artifacts, but is a trackable fiducial. And so I would argue that's probably the most useful component of the carbon fiber construct.
So even supplementation of the screws with cement to prevent pullout makes a difference. That cement within
it does. So the problem with the cement is, depending on how much is used, the Hounslow units are so similar to the tantalum tip that although you can oftentimes differentiate the screw tip from the cement augmentation on CAT scan, when you're doing the IMR tracking, it can be very difficult for the computer algorithm to identify accurately the actual tantalum amongst cement. It can be confused where the actual tip is because we take the imaging every 20 degrees. Some of the areas, depending on the patient's thickness, it can be very difficult to discern the actual screw tip. And so the cement is actually something that can be sometimes very difficult for us.
Do you find it, James, right now that there is a transition to utilizing carbon fiber exclusively whenever it's possible?
Yes, I would say right now, over the last 3 years, we've transitioned to essentially all patients coming through with a prognosis that we would feel is appropriate. All patients are essentially getting carbon fiber constructs from the thoracolumbar region, and hopefully as the development of technology gets better, we can start using it for the sacral diseases and cervical diseases as the screws become more amenable to those different size pedicles. But I think right now, essentially, if you present with a thoracolumbar secondary or primary tumor, you're very likely to get carbon fiber. And we've had a number of cases from our community sites that if you present to us with, a tumor that's not been treated or a retreatment tumor, like Dr. Kresl had brought up, we're very likely to take your titanium construct out and replace it with a carbon fiber one. So that way we can retreat the patient and then follow them what we view as more appropriate.
Maybe in the last minute or so, we can show a video about IMR, intrafraction motion review. If Dr. Kresl and Dr. Palmer, you want to briefly discuss this technology?
Of course. So for various treatment machines and for radiation oncologists, we have the capacity to do onboard imaging during the treatment itself. And that allows us to, with say titanium or non-fiducial hardware, we can track the entire construct. That's a subjective way to monitor for motion, where we have to actually objectively visualize ourselves if a construct is moving more than a millimeter. And so there is some subjectivity or inability to actually track that in an objective manner. With a fiducial marker, and this is what we use for radiosurgery for things like lung tumors, liver tumors, prostate tumors with gold fiducials. What we've noticed with some of the carbon fiber constructs, like Dr. Mendel had mentioned, that there are some that have a tantalum tip that can actually be monitored just like a prostate fiducial or a liver fiducial or pancreas fiducial. Those can be monitored real time during the therapy, and then the computer can tell us if the patient is moved. And we utilize that to then determine if the patient needs to be re-imaged and placed into position again, or if the patient gives us confidence that the patient treatment delivery was given with high fidelity, that the patient moved less than a millimeter throughout therapy. And so that's sort of what we developed and are using now for all of our carbon fiber patients.
Yeah, so in a similar fashion, what was being described as the second phase of SBRT, or after being able to delineate and contour your target and your organs at risk, you need to be able to then see your target during treatment and treatment delivery and confirm that the position is exactly where you think the target is, as well as the organs are organs at risk where they are located, with such a high degree of confidence that when the beam is on, you're actually hitting your target, because we now have ways of tracking and delivering beams with sub-millimeter accuracy and sub 1 degree of rotational corrections. So it is important to be able to have that ability to see the target during the treatment delivery process. And you can use fiducials, or you can use metal markers, whether it's a seed or a tip of a screw or larger metal constructs, as a surrogate for your target, because they should be somewhat fixed and move in concordance with your target or organs at risk, so you have a sense of where they are in position in space, or as the field is now moving in a direction where we're going to directly visualize our target during beam delivery and during treatment delivery with MRI imaging, or in some instances stereoscopic imaging that are taken in order to identify patient and or target movement during the treatment delivery process. So those are all important, and they're all enhanced by the carbon fiber constructs as they reduce or eliminate or at least minimize the artifact that you would see with imaging utilizing ionizing radiation, such as CT scans or just plain film X-rays, but would also be amenable and helpful when we're using MRI guidance in order to avoid the metal artifact in and around the constructs. So it has many potential benefits with regards to the different targeting and treatment delivery for radiosurgery.
And I would just add that the really interesting and great thing you saw in the video is that's essentially the patient's treatment. That entire video was one of the arcs, and there's 2 arcs for these patients. And so that 2-minute delivery is essentially the time of treatment. And what you saw was when that circle is green, it means that the computer was able to lock in to the position of the tantalum fiducial, and it was able to then tell us that it's within it, it's exactly where it was intended to be. And so those will light up yellow or red if it's in the incorrect position. So if the patient actually were to move during treatment, that was not only an example of sort of a perfect delivery of treatment, so it remained green throughout all of the 20-degree sort of X-rays that are being obtained. That if it turns yellow, that means that the patient is at a level where they may have moved. And red means that it's more than 1 millimeter away from where it was intended to be. And so if we see that that patient is red and then continues to be red on the next acquisition, that patient's treatment is then stopped and a re-image is done to then set up the patient again, as the patient may have coughed or moved slightly during the actual delivery. And historically, we didn't really know that. It was intended that, we have such a high fidelity setup for many of these patients that it's very unlikely that they will move, but we never truly knew that they would or would not move during therapy. And so with the addition of this tracking ability, we can be much more confident with our very small or no margin treatment that the patient has no movement, less than 1 millimeter of movement throughout therapy. And so I think that highlights just how crucial it is that those fiducial markers are there. And that was the case with no cement. And so you can see how nice you could see those tantalum markers throughout therapy. Each angle of the treatment was extremely crisp, and you could easily see throughout the treatment delivery.
Not knowing that, Josh, doing all of these CT myelograms followed by stereotactic radiosurgery, how often patient move during the procedure now that you can actually see it?
We've had to do cone beam CTs for essentially what we deem to be patient movement about maybe 5 up to 10% of the time. And typically it's in patients who, and sometimes you can sort of predict this, it's in patients who still have a lot of postoperative pain or have significant pain from other bony lesions and are still struggling with laying still for that 20 to 25 minute sort of setup and treatment delivery. And so I think historically we would just medicate those patients and hope that they move very little. And so I think now that we actually are monitoring, it's happening less than 10% of the time, but I think still enough that the tracking is quite helpful for those cases that we need to be able to reset up for a patient positioning error.
Wow, that's incredible.
Yeah, super helpful.
So just another advantage.
Exactly. I think, it's great that they did that. I think choosing as a neurosurgeon, choosing which construct to use, I think the discussion with the radiation oncologist of trying to determine which hardware helps your particular practice what I was going to highlight is, I think another key thing that Dr. Mendel was crucial in back when he was with the James is it's extremely important that the neurosurgeon is there during the treatment delivery and during like the contouring and delineation, so that they can actually see all the things that we're talking about. There's certain situations where it's hard to see the tumor, even with carbon fiber, or because of cement augmentation, or the rods that were chosen, or the positioning of the screws. And so each of those things, seeing it themselves is critical, I think. That then they start thinking like, well, maybe I won't do this because the radiation oncologist won't be able to see it. And I think that sort of kind of communication only really happens when you're there doing it together. And that sort of communication, I think, is critical with these postoperative patients.
Yes, 100%.
And as you asked earlier, it's also important to have them there for the first treatment. Again, depending on what your program is utilizing for its treatment platform, you can get a better appreciation of the field of view that you need in and around your target. Again, helping the neurosurgeon understand what we're looking for. But just as you asked earlier, especially with a CyberKnife, you can see that the positioning of the beam is readjusted basically every 15 seconds because there is enough movement detected every minute that you want to be able to adjust for it if you're doing a very complex case and your constraints are very, very tight. You want to be able to measure that and make those corrections so you're not overlapping into structures that are nearby.
Well, I guess we should, thank you so much. I guess we are right on time, almost, a few minutes past. So I want to introduce Max Laurans, who's going to talk to us about complication avoidance in spine tumor surgery.